Hello, everybody. My name is Joseph Kaziwe. I'm one of the cardiology registrars, soon finishing to start my consultant job. It's a pleasure to be with you and discuss with you uh, management, recognition, and management of some fast heart rate tachyarrhythmias. My subspecialty is devices, a bit of electrophysiology. And I'm based at the Northern General Hospital that is in Sheffield. So for the next 30 minutes, so I'm looking at the time. So I suppose, Dr. Thaka, 30 minutes should still be all right?
Yes, absolutely. And then we'll have 2 or 3 minutes of in-session feedback. I've got the link, which I'll just share at the end. Thank you.
Perfect. Thank you very much. So for the next 30 minutes, I do hope we can, just to revise, go through some basic interpretation of ECGs. But this time, I attended a full session from the plumbing side. This side, we're going to go, looking at the electrical side of things. I was also around for the earlier session of the pump itself, the heart failure session. Very good sessions this afternoon, sudden cardiac death. So just to look at another spectrum of the electrics of the heart. So we review some basic mechanisms of tachycardias and as well as explore some management strategies. I'm going to try to make it as interactive as possible. So we'll start off with, the general look of looking at, if we look at tachycardias, we can generally divide them into whether they are regular or irregular. So if we start with the irregular, which is on the lower side, the commonest being atrial fibrillation. Well, apart from dividing them whether they're regular or irregular, we can also look at whether they are wide complex, a wide complex QRS, or narrow complex. So we can see that if they're generally narrow complex, the commonest one I think everybody is seeing is atrial fibrillation. Then we can have flutter with variable conduction, multifocal atrial tachycardias, some might have seen. If we can have AF with aberrancy, ventricular tachycardia, I'm hoping everybody has seen one of them. If they're narrow complex, we have those SVTs. If you've worked in A&E, which I presume a good number of you will have worked in A&E, you've seen several SVTs. Then sometimes they can appear as SVTs with aberrancy. You will see that VT appears both in regular and irregular. We have, like monomorphic VT, polymorphic VTs. There is only one thing that is missing there. Sometimes, wide complex tachycardias, pacemaker-mediated tachycardias. Sometimes people who have pacemakers can be misbehaving, going very fast. So that's another thing we can add on. So gonna try to make it a little bit interactive. So we have a 24-year-old male attends ED. Today will be mainly best in ED, everybody. So the first common thing is, what is the commonest type of SVT? So we have a narrow complex tachycardia there. And what we have there is AVRT, AT. So A, atrioventricular reentry tachycardias, atrial tachycardias, and then atrioventricular nodal reentry tachycardias. And for the next part, we're going to try to see if we can go into Slido. So if you can join the quiz there, you have the QR code. If you can use your phone, I'll give it 30 seconds for us to join using that QR code so that we can answer that question. Let's get some anonymous participation. Can call yourself whichever name you call. So we have another 15 seconds before we go to the answering section. So another 5 seconds and I'll be flipping over. Yeah, good involvement there. Brilliant. Right, so what's the commonest SVT? Is it, I'm sure if you've worked in A&E or you're going to work, you've probably seen this even on the wards. And you've probably heard of these terms. What do we think it is? So I'm going to give it the next 10 seconds. And then we flip over. Perfect. So I can see that most of you have gone for AVNRT, followed by atrial tachycardia, and then lastly, atrioventricular reentry tachycardias. So I think majority of you, I would agree with you. Yeah, so that happens to be the right answer. So if we move to the next slide. So I've documented, I'm gonna have to squeeze this. I've been looking at probably myself, but I'm gonna have to squeeze. I'm gonna have to come back a little. Yeah, that is better. So I'm hoping everybody can see that well. So if we look at, yes, the normal heart conduction, we have the normal heart conduction from the sinoatrial node coming to the AV node, his bundle. We have the right bundle, the left bundle. And on this side, we've put the most common types of SVTs, supraventricular tachycardias. And so in patients, normal population statistics, when it comes to statistics, there can be a bit of variability depending on the population you're looking at. However, generally speaking, in normal populations, so 60% of the SVTs we see, this is what I've put here, 60%, they are AV node reentry tachycardias. The reentry circuit lies in the AV node. So that is about 60%. Then in 30%, that is, there is a band of a communication, an abnormal communication somewhere between the upper chambers and the lower chambers. And that causes, normally we should be having the connection through the AV node and the his bundle. However, we can have an abnormal communication somewhere here, there, that can cause a reentry between the atria and the ventricles, and that we call the atrioventricular reentry tachycardias that account for about 30%. The other common name, they use accessory pathway. And then atrial tachycardias, they happen in about 10%. So there are some ECGs that are put here as well, but we'll see that in detail as we go along. And why is that important? I thought we'd look at some basics. So we've already talked about the AV node and what it does. The common understanding or agreement relies in the way we look at about maybe 2/3 of the population have dual AV node physiology that can conduct on one side fast and the other side slow. So if you conceptually look at the AV node as a roundabout, one side it conducts very fast, the other side it conducts slow. So here is the atrial system, AV node, and here down we are having the ventricles. So we remember that we have conduction in normal sinus rhythm coming from the sinus node, coming down, slowed a bit in the AV node before it is conducted to allow the ventricles get enough blood, and then it is released to the ventricles so that they can conduct. Now there is differential properties in the conduction of both the slow and the fast pathway. And the easiest way to look at it is, the slow pathway, it is quite slow, but it has a short refractory period, whereas the fast pathway, it's quite slick, but it has a longer refractory period. So most people use the BOT physiology to sort of help people imagine it. When you have a fast moving BOT, it goes very slick, but the water takes longer to settle. Yet if you have the slow one, you won't even notice it. It requires a very short time before it can conduct again. So looking specifically at the majority of the SVTs, which we talked accounts for about 60%, atrioventricular nodal reentry tachycardias, I'm going to spend about 2 minutes to go a bit step by step to show what is happening here, to review the basics, which we probably already know. I'm hoping we can use the cursor there, you can see it. So we talked about conceptually our AV node, like a roundabout with one side, the fast pathway, the slow pathway. We already know that as slick as this it is, as slick as the fast pathway is, it takes a bit longer in the refractoriness before it can conduct again. And the opposite one, the slow pathway, it is very slow, but it takes a very short time before it can conduct again. That is the refractory period. So in normal sinus rhythm, we have the impulse coming down, going down in the fast pathway, going both ways, fast and slow. But because it goes, the fast pathway is quite slick, it conducts to the ventricles and it comes here via the slow pathway where it was also conducting, it cancels itself out. And we have normal conduction. So we have the P wave, we have the QRS, and the repolarization. And that is how we have our normal sinus rhythm. However, when conditions and timings are right, in the sense that common precipitant for these SVTs is a premature atrial beat, and if it is timed in such a way that it comes down, so it is not coming from the sinus node, it is coming somewhere from the atria, and that is why, it's coming down here. So if it comes down at the time when the first pathway is still refractory, it cannot be conducted. So it is conducted in the slow pathway. Why is it conducted in the slow pathway? Because remember, the refractory period is fast shorter. If it comes down here and this pathway is still, comes down the slow pathway and the fast pathway is still refractory, it cannot go back. So we have a pack conducted just like that. But if it times in such a way that the refractory, by the time it comes to the ventricles, the fast pathway is out of refractory period, is now able to conduct, then we can have it propagating backwards. And that means that we have simultaneous conduction going down and simultaneous conduction going up. So we have the pack timed in such a way that it found this refractory, it has come down. By the time it is going to the ventricles, the first pathway is out of the refractory phase and is able to conduct backwards and very slick. So you end up with a re-entry circuit formed around this roundabout, and you're having simultaneous activation of both the ventricles and upwards to the atria. And this is what we are seeing here. So it's coming down the pack, and we have conduction downwards. This is to the ventricles, and almost at the same time, usually we call it simultaneous, we have the atria. And so many times in the SVTs, we're not going to be able to see P waves. However, if you look closely in some of the leads, we can be able to see the P waves appearing at the end of the QRS morphology. And this is what we've shown here. So this shows the reentry circuit, and you have simultaneous activation. This is your SVT, the AV node reentry tachycardia. Remember, we talked about how it was set off by a pack. And if you look closely, so we have lead 2, it looks inferiorly, and we have the right precordial leads. Because of the simultaneous or almost simultaneous activation, you notice that we get, remember, this is going upwards. We have activation going upwards from the atria. So we have a pseudo S wave in the inferior leads, and we commonly have a pseudo R wave in the in V1. So those are things to remember. We will have a look more at them. So if we use some examples. So we have a 37-year-old female with palpitations and transient loss of consciousness. So you'll see that term T-lock. She comes to ED. She has a blood pressure of systolic of 75, and she's having chest pain. She's going quite fast. You do the ECG, it is that. What is the appropriate management, next appropriate management plan? Are we going to do vagal maneuvers, IV adenosine, an emergency DC cardioversion, or amiodarone? Again, we are going to go to, we go to Slido. I'll give it 30 minutes again if we can join, or we already joined. I suppose we already joined. For those who have not joined, we'll give you another 10 seconds. So we've seen a narrow complex tachycardia. We know that it is most likely to be an AVNRT. We've looked at the mechanisms. What is the appropriate management option? So give it 20 seconds in the interest of time. See what people think. Should we proceed with vagal maneuvers, IV adenosine, cardioversion, IV amiodarone. So giving it another 10 seconds. Okay. Right. So most people have gone for vagal maneuvers and then followed by emergency DC cardioversions, a few, adenosine and amiodarone, very good. So that was one of those ones I inserted in, and that highlights a learning point, plus the basics. So clearly, so the correct answer here is DC cardioversion, but why is it the case? Let me see if I have it. Yeah. So we have a narrow complex tachycardia. So it tells me that people are aware of how to manage narrow complex tachycardias. So if the patient is clinically stable, the blood pressure is okay, they don't have chest pain, they don't have adverse features, then we manage with vagal maneuvers, as we've said. But the only difference I've made this time that this patient is hypotensive. If you remember, this BP was 75, is having chest pain, so we need to cardiovert them. But otherwise, it tells me that people know how to manage these patients when they are well. But if for any rhythm beat, narrow complex, regular complex, if you have adverse features, the next thing is to shock them. Now, we've already looked at this, and as I said, so I've put side by side the sinus rhythm ECG and when they are in the tachycardia, the SVT. And just to highlight the issues we've talked about, we've gone through this mechanism, and we remember that we talked about in inferior leads, you might be able to see these P waves. It's like pseudo S waves. We've talked about them here. And why are they pseudo? They are negative here because the axis of activation is going backwards. Remember, in sinus rhythm, you're going to be having the axis of activation of the arteries coming from the sinus node going down. So it should be positive, but this is the reverse in AVNRT. So you have them negative, and they usually are next there. Sometimes you don't see them, but if you look carefully, so if you can see there, this is in lead 2, you can see, look at the lead 2 there and lead 2 here. So lead 2 here is very clean, as you can see. So this is in sinus rhythm. But if you compare it in the tachycardia, you can see that there is some pseudo S waves there. Of course, you need to be knowing what to look for to find them. And we know why they are there and why they are negative. It's because of the axis. So we know that you see the P wave is positive. It's inferior because the axis of activation is from sinus top coming down. The reverse is true because you have the AV node reentry circuit and it's activating the atria backwards. So if you're in the inferior leads, the wave of activation is going to be negative. That is why they are negative in there. And again, we talked about the pseudo R wave, again in V1. So if you look at the V1, in sinus rhythm, and you need to compare it to V1 when they're in the rate. And most times you can convince yourself that you can see the pseudo R wave. So things to remember here is that when you have narrow complex tachycardias, most commonly there's a high likelihood they are AVNRT. The typical one is the slow fast pathway. We've looked at the mechanism. If you compare sinus and tachycardia rhythms, you can be able to pick out those ones. And also there is what they call the RP intervals. So we know that these are the R waves. So we have the P QRS and we have the T wave. So we have this as the R interval. And we have this as the PR interval. And we can get from here, this is the P wave to here. So we can call this the RP interval. So there is something called the RP interval, and that means from the R wave to the P wave. So you can see it is typically very short. So if you see in sinus rhythm, so this is the RP interval, it's quite there, more than 2 squares. So this is 400, this is 200, 200. So that's already 400 plus another maybe 40, 440 milliseconds. That is the RP interval. But if you see here in the pseudo waves or the pseudo R prime, you have no more than 2 squares, about 80 milliseconds. So there is commonly typical slow fast atrioventricular nodal reentry tachycardias. They have a short RP interval, and that is why, because you have simultaneous activation of the atria and the ventricles. Again, as we've been summarizing, so we have reentry circuit in the region of the AV node. Most common SVT, we saw it about 60%. If you want to terminate it, as you've already known, that you can use AV node blocking drugs, and you break the circuit. All AV node blocking drugs can be useful. In the A&E, you commonly use adenosine, but also, so that is to manage, so you manage the tachycardia, they go back into sinus rhythm, and intermittently they'll be back in the tachycardia. But there is a role you can actually cure it using catheter ablation. So these patients, when you see them, you've given them adenosine, they're feeling well, they're going back, refer them to cardiology for a catheter ablation. So it's called slow pathway modification. They can go into the lab, they have a procedure, 95% effective, and they do not have those recurrent tachycardias. So again, get ready, I suppose. So typically the following is true. AV node reentry tachycardia is a long RP, narrow complex tachycardia, while atrioventricular reentry tachycardia is a short RP. We know what RP is, now narrow complex tachycardia, or the other way around. I'll give it 10 seconds. So AVNRT is a short, yes. So we've already now discussed that. So AVNRT we know is a short RP, narrow complex tachycardia. And why? Because we have simultaneous activation of both the chambers, while a typical AVNRT is a long RP, narrow complex tachycardia. And just to highlight what we've already talked about, what we call the RP, remember this is the RR interval. So RP, we now talked about this pseudo S wave. So we know that from the RP, it is very short, usually less than 80, 90 milliseconds. And in a typical, the other one, which is the atrioventricular reentry tachycardia. So this one is the AV node circuit, as we can see, with simultaneous activation. We've already discussed it. That is the AVNRT. But if we have a communication somewhere between, we have an accessory pathway. So that gives us an atrioventricular reentry tachycardia. So you have the pathway coming down. It's going to be a narrow complex because it's coming down the Purkinje, the conduction system. But you can see that it takes a longer time to go back via the accessory pathway to activate the atria. And that time is going to give you a longer activation from the ventricles going back to activate the atria. So those tend to have a longer activation of the ventricles to activation of the atria. So a longer RP interval as demonstrated here. So you'll be hearing words like short RP, long RP intervals. And those give you an idea where the circuit is. And basically it is knowing the anatomy. This is all near with simultaneous. So you have shorter RP intervals, but this one takes a longer time from the activation of the ventricles going back through the accessory pathway to activate the atria. So we now turn to the other side of the AV node when you have an accessory pathway. So accessory pathways, we've used this one as a schematic. So if you have the accessory pathway, it can conduct backwards, it might conduct downwards. So there are words you will be hearing like orthodromic and antidromic, but basically just means, if you have an accessory pathway, it can give you both narrow complex and big complex. And why is that the case? So we know that if it is conducting upwards and it's coming down, well, let's put it this way, the other way to look at it, we know that the QRS complex is going to represent the activation of the ventricles. If it is narrow, it means it's been conducted via the sleek pathway. So if you have downward conduction via the sleek pathway, you're going to have a narrow complex QRS. And then it goes back. This is our typical long RP, atrioventricular reentry tachycardia. But if it is the other way around, so now we have conduction that is going retrograde via the normal conduction system. So we are activating the atria via the accessory pathway. So remember, this is specialized tissue. It is very sleek. It conducts very fast. The accessory pathway is going to come and activate the myocardium directly, not via the specialized conduction. So the activation of the ventricles is going to be slow. And that, because it is slow, remember, ECG is versus time. So you're going to have slow, you're going to have a wide QRS complex. So wherever you have activation, pre-excitation, what we call pre-excitation, you have via the myocardium itself, which is slow, you're going to have wide QRS complex. If you're activating via the specialized system, it's going to be narrow complex. And that is very important. Here is an example. If you have another narrow complex tachycardia, it's very narrow, so we know that it might be an AVNRT or it might be an AVRT. But then when we look closely, we know that the conduction is down conduction has to be down the specialized system because it is narrow complex. But if we look closely, we can see that actually what we are seeing some P waves marching through. But these P waves are marching a lot later, unlike the ones we saw before. And if you look through other leads as well, you can see where they are marching, but they're coming along a lot later. So this is more lying towards a long RP, narrow complex tachycardia, which we know is more likely to be an accessory pathway that is conducting via the specialized conduction system, as we have looked at. So we have another couple of minutes remaining. So we have a 19-year-old male. So we have about 10 minutes or so. 19-year-old male attends A&E following a transient loss of consciousness. You have a look at the ECG. I will not take a lot of time. So we can see the ECG in sinus rhythm, but you can see there's a short PR and potentially a delta wave there. So this is going back to accessory pathways. If you look at that, so you wonder, is there a short that? Again, question, what is the general half-life of adenosine? I'll give it 10 seconds because you either know it or you don't. And there we go. Okay. And another good learning point. So I can see 60, 2 minutes and whatever. So we have a good spread everywhere. So 10 seconds comes out, that is the most consensus. So adenosine is such short-lived. It has a very short-lived half-life. So when you give it, some of you will be in A&E, we've given it, it's such a short-acting half-life. So if you remember, we talked about nodal reentry circuits. We cannot use always AV node blocking drugs, but some stay longer. So you want something that can stay for a short time. So the premise of that slide is to talk about adenosine, what it does, and what you should be expecting. I suspect many of you have used it. So this is, in the other example, we are seeing a short PR. Why a short PR? Remember that the AV node, I don't know if I have that slide. No. Okay. So I'll just come back a little bit just to explain those features. So two main things we've seen on that slide. Remember that if you have a circuit that is coming down, if you have sinus rhythm and you have an accessory pathway, it comes down, it can go here, and it can go via there. So you can have conduction down to the ventricles via both the specialized system and the non-specialized system, the accessory pathway. So we know that in the AV node, it delays things so that the atria, normally the AV node does not transmit, but the accessory pathway does not have those properties. So once the sinus node fires off here, you have delayed activation of the ventricles in the AV node, which is very useful, but the accessory pathway is just going to let it go. So you have a short PR because of that. But remember also, because you're having the myocardium itself, the big one, so you have activation, a broad complex. But because you have both, it's going to delay a bit. It is not going to delay a bit. So it gives you a short PR. It starts the broad complex, but as it goes through here, it goes very slick. So you have a fusion of this and that. So, and that is how we end up with the delta wave. The delta, so we know the short PR is because there is no delay normally there is no delay in the accessory pathway. And what we can see, so it starts off as broad, but eventually the specialized conduction system catches up and takes over. So you have like a fusion of what was going to be a big one in the narrow complex, giving you the so-called delta wave. So one of the things, if you see in A&E somebody who you suspect, you're not sure whether they have something or not, one of the drugs we can use is adenosine to unmask these. So you'll have heard of adenosine tests. So this is an example, somebody connected to a monitor, you think you've suspected there is a potentially pre-excitation. So you have these narrow complexes, you give them a shot of adenosine, and what adenosine is going to do is going to block the AV node, and that means you're conducting via the accessory pathway. And what is happening, you're going to have from the sinus bit, you're going to have now conduction via the accessory pathway, which is a broad complex because it's not using a specialized conduction system. In that way, you can sort of know that, oh, this patient has an accessory pathway. So this is an adenosine test. That's how it would look on the ECG for somebody with an accessory pathway that conducts downwards. So things to remember, adenosine challenge. So it can, one, we use it in A&E, as you've seen, to terminate SVTs. It has a very short half-life. Don't be worried about it. It can be used in the diagnosis of arrhythmias, AF and flutter. So if somebody comes with a narrow complex and it's a flutter or AF, you give them the adenosine, it's going to cut off the AV node temporarily. You should be able to see the flutter waves. And then after, about 10, 20 seconds, you can have back your conduction. Things to remember, if it is a VT, you're not going to have any effect on it. Should be conscious. If people who are asthmatic, adenosine can make vasoconstriction worse. Remember to have defibrillation pads whenever you're doing that test, because it has, although it makes accessory pathways slicker, but also on the atria, the effects is that it can give you AF, it can induce AF, which can go down. So always do it in a safe environment. So this is, again, somebody with an accessory pathway. And what we are showing here, so you can see short PR, query delta wave. And on this ECG, you can see, so this is one sinus beat, sinus beat, sinus beat. Then this one comes early, a PAC, as we talked about. We know that it is coming from up because it's downward activation. It comes and sets off a narrow complex tachycardia. So we can see an example of somebody with an accessory pathway who is going into AV reentry tachycardia on this ECG. So this is the mechanism we've been talking about. You have activation from here and you have conduction here, giving you a short PR and a broad complex, which catches up with another one quickly. Usually we've talked about the delta wave. We've talked about why it is big, and sometimes it can give you symptomatic tachycardias. So in the last 2-3 minutes, as we wind up, we're going to look at that ECG. So in the ECG for that exact same person, you have the patient that I've shown you before. While they are monitored there, they go into this broad complex irregular heartbeat. And the question is, should we give them adenosine, vagal maneuvers, DC cardioversion, verapamil? They are GCS 15, they are pain-free, they are looking at it, they are well in themselves. And that will be the last answer. Need to be finishing in the next 2 minutes. I'll give you 5 more seconds. Okay, so appropriate management. So emergency DC cardioversion, very good. So this is so it's worth it for us to go a bit 2-3 more minutes. So because we have 17%. So in patients, the right answer here is 17%. And why is it the right answer? Well, we forget about the score there. So this is AF with pre-excitation. So it is, we know that we are having broad complex tachycardias, but we can see they are quite irregular as well. So whenever we are seeing this, we need to be aware of, if patients who have an accessory pathway, they have AF, they can be conducting down here and conducting through here. So we know that the broad ones are mainly through here and the narrow ones are through here and some are in between. So AF with pre-excitation gives you a fast, broad complex that is irregular, and regardless of how the patients, what you don't want to do, if you give them an AV node blocking drug, you're going to have conduction all through here. So which is going to accelerate. This one does not stop anything. Remember, we talked about the properties of the AV node. It's somehow protective. If you're going to tachycardias like AF, you're having about 600 beats per minute. It only lets in a few. It selects, it filters, but the accessory pathways commonly do not filter. So you conduct here first, it's going to conduct everything down, and you have 200 beats per minute, 300 beats per minute, you will degenerate into VF. VT, VF, and the patient is likely to die. So patients who come in with broad, complex, irregular tachycardias, always be mindful that if we give them any AV node blocking drug, we might actually make them worse. So the optimal treatment here is actually giving them a shock. Do not mess with fast, broad, irregular complexes. AF with pre-excitation, remember not to shock them. So as we wrap up with the last slide, I hope this session has given you an eye. We've been able to recap a little bit on how you can look at narrow complex tachycardias and have an idea on which one is likely to be a short RP, narrow RP, and the mechanisms. We've looked at the nuances of using adenosine, including the risks it brings. And if we have fast, broad, irregular complexes, tachycardias, even if the patient is looking well, we need to remember not to use AV node blocking drugs because of the properties we've looked at. And for those patients, they should not leave hospital without having an ablation. We need to refer them to cardiology, get an ablation of the accessory pathway, and it can be cured. Thank you, and I'm happy to take any questions. Thank you.